Basic Principles of Internal Fixation. This is from the OTA Core Curriculum Resident Lecture Series version 5. Slides are by Dr. Steve Papp, and I'm Saqib Rahman narrating for you. So objectives are to learn about bone healing, learn about types of fixation constructs, how to optimize them, and then we'll summarize. So there is natural or sort of secondary bone healing as well as primary bone healing. And secondary bone healing or natural bone healing is a very well-established process with 3 or sometimes broken down to the 4 stages of healing that eventually improve the stability of your fracture. And you get sort of this hematoma and then soft callus, hard callus, and then remodeled bone that has increased structural quality as you go over time. And that's shown here. So the early phase, which is the first several days, there's an inflammatory phase where there's a fracture hematoma, there's a fibrin clot, there's granulation tissue, and then eventually that starts to go over several weeks into a soft callus. We have a cartilage formation through this sort of immature woven bone that eventually becomes a hard callus. And ossified cartilage, and then eventually over time that's replaced by lamellar bone in a remodeling phase. So those are sort of the 3 phases. That second phase is sometimes broken down into a soft callus phase and hard callus phase to make it 4 phases. So the initial phase provides very little stability, and there can be potentially quite a bit of deformation as shown here, whereas in the soft and hard callus phase there is much less deformation that takes place. In that middle phase you will get cartilage and soft callus that's deposited. It offers a little bit of stability. It's less tolerant to deformation, and as that gets bigger the stability increases, and a patient will often feel this if it's in a location that's palpable. And then endochondral ossification occurs, further stabilizing the bone and forming that radiographic callus that you'll see. And then the late phase is remodeling, and over time the strength will increase, and sometimes you can even have a healed fracture be stronger than the original bone was in the first place. So with primary bone healing, this is actually not the natural bone healing. This is sort of unnatural bone healing, and this relies on direct remodeling of bone. And this only happens when you do compression plating, an anatomic reduction of a fracture. And then what happens is osteoclasts form these cutting cones that go directly across the fracture, and osteoblasts form new bone. And it's a little bit similar to how bone remodels in response to stresses. And you just don't go through these intermediate stages. So you don't really get callus. You just kind of go from a fracture to then sort of a remodeled bone. If you have gaps and you did not compress the fracture, though, that's going to prevent osteoclasts from crossing the fracture site. Even in the most anatomic reduction, there's going to be small gaps that can be filled in with lamellar bone and remodeled, but it's got to be really small if you want to get primary bone healing. So direct bone remodeling also needs to be, the environment has to be fairly rigid and also have low strain. So a simple fracture, like a short oblique fracture treated with anatomic reduction and rigid fixation, can heal by primary bone healing. You got to get interfragmentary compression, and then oftentimes if it's a diaphyseal fracture, neutralized plating or compression plating. And if you have that simple fracture that's not anatomically reduced with a gap, and then you also do rigid fixation, you will have a very high strain environment. You really have to kind of go and sit down and review Stephen Perrin's strain theory of fracture healing to understand this concept. A little difficult to just explain very easily in a short slide presentation. And if you have a high strain environment, that's at risk for fibrous tissue formation because you can't form bone, and non-union. So if you try to get primary bone healing, you have to strive for meticulous anatomic reduction, get compression, And this is easier to do if you have sort of simpler fracture patterns. Other things to consider are the biologic environment, the biomechanical environment, and these two things can often be competing with each other, as we've talked about in another video. What about screw fixation? Well, screws are used for various reasons. They can secure a plate to bone, they can compress a fracture, they can just sort of stabilize without compression like a position screw. They can serve as an anchor for cables, wires, screw fixation, etc. Let's talk about the anatomy of a screw. Well, you have the screw head. That's not really shown here, but that's where the screwdriver will engage the screw, and this where the screw will engage like a plate or the cortex of the bone. There's this inner or core diameter as shown here. There is the outer diameter. There is thread depth and pitch. And all these things can potentially vary depending on the screw you're using. The tip of the screw can have cutting flutes. And if you look very carefully here, you will see there's sort of this, this is a self-tapping screw. It has this cutting flute, whereas this here is a very standard non-self-tapping screw. The threads will help to purchase bone, and then the screwdriver, of course, will engage the screw head. And the screw head also is what acts as the final buttress to the plate or bone. Otherwise, the threads would just pass all the way through. And headless screws also exist, where you need to have a head countersink all the way below the surface. So, to resist fatigue failure, what can we do with the screw? Well, we can increase the inner root diameter, and we know that diameter to the fourth power. So if you increase 1 millimeter from 1 to 2 millimeters, and the strength is increased at the fourth power, you'll actually have a 16 times increase in strength. What else can we do to increase pull-out strength? Well, we can increase the outer diameter, right, of the threads. We can decrease the inner diameter. We can decrease pitch, or if the bone has increased thickness of the cortex, that will help your pull-out strength, or if the cortex is simply more dense. And obviously the opposite is true too. An osteoporotic bone, our pull-out strength is going to be compromised because of the bone. So what about cortical versus cancellous screws? And if you look carefully, these screws look a little bit different here. In the cortical screw here on the left, it's obviously used in cortical bone, where the bone is more dense and there's sort of less volume there. It's a smaller pitched screw. The thread depth is also smaller, although that's not crucial. The cancellous screw used in cancellous bone, like in the metaphyseal portion of a long bone, it has a larger pitch, deeper threads, as you can kind of compare this screw with the other screw. And if you pick up two screws of similar size, like a 3.5 millimeter cortex screw and a 4.0 millimeter cancellous screw, and take a look, you'll be able to recognize the difference. What about locked screws? So with a standard screw, as shown here, you can see the screw head sort of just centers itself inside the hole and has sort of this shape here that recesses nicely there, but it doesn't lock. And if you look at the locked screw over here, you can see this screw has threads, and the threads match sort of in this particular plate design. It mates to the threads in the screw hole. So essentially, though, whatever the design is, the screw head is supposed to lock into the plate and create a fixed angle, so it cannot toggle, right? So this screw, cannot sort of toggle in this direction, whereas this one potentially can, depending on, the biomechanics of the environment and the bone, etc. A locked plate construct does not rely on plate-bone friction for stability. So here you can see, there's no gap here, right? This plate comes down to the bone. Here, there's a gap, right? So this plate, if it's put with all locking screws and there's no clamp to sort of bring the plate down to the bone, the plate can sit like this, or like what we'll call an internal-external fixator type design. What about cannulated screws? So these are screws where there's a cannulation down the center. It allows you to place the screw for guide wire. So let's say you're targeting a very small fragment that may take more than one try to make sure that you're perfectly positioned where you want to be. Well, a pin can be much less traumatic to do that, and you can then place the guide wire first, measure, then you do a cannulated drill over this wire, and then the screw goes over the wire as well. So you have to increase the inner diameter to improve the strength of cannulated screws, because you're cannulating out. It's not a solid screw anymore. So to make up for it, you can increase the inner diameter. When you do this, screw strength is minimally affected. What about lag screws? Now, whereas you can ask your surgical tech, can please hand me the cannulated screw, you can't really say hand me the lag screw. So lag screw can be a lag screw by design. So if you have a partially threaded screw, that can act as a lag screw. Or you can use, for example, as shown over here, you can use a Cortex screw with appropriate drilling of a gliding hole. So you can see the gliding hole is sort of matches the outer diameter of the threads. And then here you have a pilot hole that approximates the inner diameter. So if this is a 3.5 millimeter screw, you would drill this is a 2.5 pilot hole. This would be a 3.5 gliding hole. And that allows you to generate compression with a screw like this, and that's called lag by technique. Now, you could do the same thing in this case by just placing a screw that's partially threaded. So the screw engages here, it does not engage here, and you can achieve compression. But you still have to say, give me the partially threaded screw, give me the fully threaded Cortex screw, and I'm going to, perform a lag technique. Here are those steps. These are some of the AO slides demonstrating reduction of the fracture. Notice how the lag screw is done perpendicular to the fracture line. So the gliding hole is drilled. There's a countersink that's done here. And then you can see then the pilot hole is drilled after a centering sleeve is placed, and this is going to be smaller than the gliding hole. And then you take a measurement, and then you place your screw, and you can see once you engage the far cortex. Now, the screw will not engage the near cortex. It'll slide right through, engage the far cortex, and then now you're relying on that screw head hitting the bone, this engaging the cortex here, and then providing that compression. So the compression happens once that head hits the near cortex. So how many lag screws you place could depend on the length of the fracture. So if you have a very long spiral fracture, you can sometimes place multiple interfragmentary screws as shown here. All right, well, let's pause here, and then we will pick up talking about plates in the next video.